Hello everyone, this is Dr. Garima Sachdeva, one of the mentors of studying RCOG, and today's wisdom short is on the management of ovarian cyst in premenopausal female. So first we classify the ovarian cyst as benign or malignant based on the B or M rule. So B rule means benign. So what are the characteristics of benign? So if it is unilocular, if the solid component is less than 7 mm. So even if the solid component is 6.9 mm, it is considered benign. Okay. If acoustic shadowing is there, or it is a smooth multilocular tumor with the largest diameter less than 10 centimeter, or there is no blood flow. So these are the 5 benign features, also known as B rules, according to the IOTA classification. Then what are the malignant features? Features pointing towards malignancy, M rules. If it's an irregular solid tumor, if it's ascites, at least 4 papillary structures. So if 3 or less papillary structures are present, then it is not an M rule. Or if there is irregular multilocular solid tumor with largest diameter more than equal to 10 centimeter, or the blood flow is very strong. So in case any of these M feature is present, you refer them to gynecological oncologist. So this is important. If M feature is there, you directly refer them to a gynecological oncologist. So once a patient comes with ovarian cyst, what all blood tests you should order? So in simple ovarian cyst, you need not do CA-125 or any other blood test. However, if there are complex ovarian masses in a young female who is under 40 years, you do LDH, alpha fetoprotein and HCG because there is a possibility of germ cell tumors. So CA-125 not necessary in simple ovarian cyst. For complex cyst in a female who is less than 40, you do LDH, alpha fetoprotein, HCG to rule out GCTs. So coming over to the management of simple cyst in a premenopausal female. So if the cyst is less than 5 cm, they do not even require a follow-up because they almost always resolve within 3 menstrual cycles. If it's 5 to 7 cm, yearly you have to follow up these patients for the change in size or the characteristics of the cyst. More than 7 cm, you have to intervene. You either do an MRI, or if the patient is symptomatic, you can do a surgical intervention. And since it's a premenopausal young female, in these cases, cystectomy is preferred over oophorectomy. And if the cyst is small, like it is less than 5 cm, you need not even give them OCPs because they do not promote resolution of functional ovarian cyst. So for simple ovarian cyst, COCs usually do not help. You just simply, for less than 5 cm, you do not follow up. 5 to 7 cm ultrasound follow up on yearly basis. More than 7 cm MRI or surgical intervention. Then if it's a dermoid cyst, because these dermoid cysts or mature cystic teratoma, they grow over time. And the patient presents with features of there is increased risk of pain and ovarian accidents like torsion. So they require surgical intervention. What is a surgical intervention? Again, in this cases, it is cystectomy because it's a young female who do cystectomy, which is preferred over oophorectomy. And this what route for cystectomy should you follow? If the cyst is less than 7 cm, you do laparoscopy. If it's more than 7 cm, it is large, then you prefer it removing with laparotomy because then there is higher risk of spillage and it can cause chemical peritonitis. So this was all for this wisdom short. I hope I have made things very clear. In case of any doubt, you can get back to me. Thank you so much.